Hi and welcome back to another video of Medic Notes. In this video I will be explaining on the causes and management to correct hypernatremia. First I will start with the causes of hypernatremia. It can be due to inadequate water intake. Fluid loss due to many reasons. For GI system, patient might have had vomiting or diarrhea. Fluid loss through skin, such as excessive sweating or burns. Renal fluid loss, like cases of diabetes insipidus, osmotic diuresis, or diuretic therapy. Third cause is salt gain. Can be either excessive sodium intake, or due to mineralocorticoid excess, in hyperaldosteronism, or Cushing's syndrome. Clinical features of hypernatremia. So hypernatremia is defined as sodium level more than 145 millimole per liter. Normal value is 135 to 145. Most outpatients are either very young or elderly, whereas hospital-acquired hypernatremia affects patients of all ages. Unlike infants, elderly patients generally have few symptoms until serum sodium exceeds 160 millimole per liter. The clinical features include tremulousness, irritability, ataxia, spasticity, mental confusion, and even coma. Diagnosis would require an identification of etiology. Next, let's look at the management of hypernatremia. The management depends on type of hydration, cause, and time period of development. Target fall in serum sodium concentration is 10 millimole per liter per day. If patient with long-standing hypernatremia is infused with hypotonic fluids, there is a danger of cerebral edema. Hence, it is essential to lower extracellular hypertonicity slowly. In hypertonically dehydrated patients, such as 0.5 millimole per hour. If hypernatremia developed over a few hours, rapid correction, 1 mmol per hour, may not increase risk of cerebral edema. Remember, treatment of etiology is important. The etiology can be due to water depletion or salt gain. First we look at how to manage water depletion. This is the formula for calculation of sodium correction and volume required. Total body water equals to current body weight times fraction of body water. This fraction of body water differs with age and gender. It is 0.6 in children, 0.6 in men, 0.5 in women, 0.5 in elderly men, and 0.45 in elderly women. Let's go through once first and later I will show an example scenario for better understanding. Next, to calculate change in serum sodium, it is equal to infusate sodium minus serum sodium, and then divided by total body water plus 1. So what is this infusate sodium? We can give dextrose 5%, or 0.45% sodium chloride. Dextrose 5% provides 0 millimole per liter of sodium, whereas 0.45% sodium chloride provides 77 millimole per liter sodium. Remember these two numbers. We will need it later on. So in cases of water depletion, water should be given orally if tolerated. If not, set up an IV infusion of D5% or 0.45% NaCl. Next slide. Calculation of volume required to be administered to the patient. The volume administered is water deficit, plus daily requirements, plus ongoing loss. Water deficit equals to current total body water, times serum sodium divided by desired sodium, minus 1. The total body water is calculated here just now, whereas the daily fluid requirements is 40 milliliter per kilogram per day. Next slide. After deciding the volume to give, we have to calculate the rate of correction. Hypertonic patients should have their hypertonicity resolved slowly. Recommended correction of plasma sodium concentration should not exceed 0.5 millimole per liter per hour, or 10 millimole per liter per day. Due to risk of overcorrection, the patient's sodium levels should be repeated every 2 to 3 hours initially, and then at 4 to 6 hours intervals. Okay, after going through those formulas, let's try to see this example scenario. A 60 kilograms female, hypovolemic patient, presented with severe obtundation with sodium level of 165 millimole per liter. First we calculate the change in serum sodium, which is infusate sodium minus serum sodium, divided by total body water plus 1. Identify time period of desirable correction, for example 10 millimole per liter in 24 hours. If we are giving 0.45% sodium chloride, 1 liter of 0.45% sodium chloride will reduce the sodium concentration by how much? So using this formula, infusate sodium minus serum sodium. If you look back here to this slide, let's see. 0.45% NaCl provides 77 millimole per liter of sodium. So back to this question. Infusate sodium we put 77. Serum sodium is 165 for this scenario. Then divided by total body water plus 1. Look back to this slide. Total body water is current body weight times the fraction. So in this scenario, 60 kilograms times 0.5 for women. That's how we get the 30. So 1 liter of 0.45% NaCl will reduce sodium concentration by 2.8 millimole per liter. To aim for millimole per liter sodium reduction, 10 divided by 2.8 will get 3.6 liter. So 3.6 liter of 0.45% sodium chloride need to be infused over 24 hours. So the infusion rate is 150 megaliters per hour for 24 hours. On the other hand, if we are to give dextrose 5%, using this same formula, but dextrose 5% provides 0 millimole per liter of sodium, so 0 minus 165, divided by 30 plus 1, we get 5.3 millimole per liter. Aiming for 10 millimole per liter sodium reduction, 10 divided by 5.3 will equal 1.9 liter of dextrose 5. So it needs to be infused over 24 hours as well. Also, remember to add the daily requirement and estimated ongoing loss into the total amount to be infused over 24 hours. Next, water depletion can also be due to diabetes insipidus. And there is specific management for this condition. There are 2 types of diabetes insipidus: cranial and nephrogenic type. For cranial type, we give desmopressin. Oral. Desmopressin, 0.05 to 0.2 milligrams, 1 to 3 times daily. Or intranasal 5 to 20 microgram, once or twice daily. And sub-Q'd or IV. 0.5 to 2 microgram, once or twice daily in acute situation. Whereas for nephrogenic type, give thiazide diuretic, with or without prostaglandin synthetase inhibitors, such as amiloride, with or without indomethacin, plus modest sodium restriction. Lastly, another cause of hypernatremia is due to salt gain. We can give potent diuretics such as IV furosemide. At the same time dextrose 5% is infused. Dialysis may be needed in some cases. That's all for this video. Thank you.